Imagine being handed a tube of, life-saving medicine, but the warning label on the back terrifies you so much that you refuse to use it.
Right,
You
yeah.
just tuck it away in a drawer somewhere while your symptoms just get worse and worse.
Uh,
Today, we're looking at this medical detective story where the culprit behind a really alarming symptom could be a deadly cancer
mhm.
or it could just be plain old fear.
I mean, it is a massive clinical paradox. We're talking about a scenario where the sheer anxiety around a treatment can actually mimic the progression of a lethal disease.
Wow. Yeah.
And untangling those two possibilities, it requires a very specific kind of clinical investigation.
Well, welcome to this deep dive. If you're joining us today, you are probably the kind of learner who wants to just bypass all that overwhelming flood of medical jargon and get straight to the critical aha
Yeah.
moments. We're stepping into a diagnostic landscape today that is the absolute definition of murky. We're focusing on a highly specific mission, like how does a clinician evaluate a non-healing vulvar ulcer in a patient who already has a long-standing diagnosis of lichen sclerosus?
Yeah, and to get to the bottom of this, we're pulling from a pretty heavy stack of specialized clinical guidelines.
Which are dense, by the way.
Oh, incredibly dense. We have the
Mhm.
British Association of Dermatologists, the European Guidelines on Vulval Conditions, and the NICE urgent referral pathways.
Right.
But at their core, they provide this essential roadmap for spotting the true signal, through the constant confusing noise of a chronic disease.
Okay, let's unpack this. Before we can even talk about evaluating this ulcer, we really have to understand the terrain it's sitting on,
Yes, the baseline.
right? The baseline of long-standing lichen sclerosus or LS. Because, we can't identify an anomaly if we don't understand the normal environment or, the new normal for a patient living with this condition.
That baseline is everything. Because lichen sclerosus, it's a chronic inflammatory autoimmune condition,
Okay.
and it fundamentally alters the landscape of the vulvar skin. I mean, over time, it causes these chronic architectural changes. The skin becomes atrophic.
Getting thin.
Yeah, incredibly thin, white, and it often takes on this crinkled appearance, almost like tissue paper.
Oh.
And there's often this characteristic figure of eight pattern of pallor around the vulva and the perianal area.
But it's not just a surface level texture issue though, right?
Yeah,
Reading the sources, the actual anatomy changes.
it does.
They describe a loss of the interlabial folds, a flattening, or even like a complete resorption of the labia minora. And in advanced cases, there could be actual tissue fusion.
Right.
But how does that happen mechanically? Like, how do distinct anatomical parts just fuse together?
Well, think about what's happening on a cellular level. The chronic inflammation is essentially destroying the superficial layers of the skin, which leaves the tissue underneath raw and exposed. Now, when two raw, inflamed surfaces are in constant contact, which, is naturally the case in vulvar anatomy, the body's misguided healing response is to bridge that gap with scar tissue.
Oh, so it just heals them together.
It essentially glues those structures together, yeah. That's how you get clitoral phimosis, where the clitoral hood scars over and just completely buries the clitoris.
So living with long-standing LS, it's a bit like living in an active geological fault zone.
That's a good way to put it.
You already expect some tremors, some shifting ground, structural changes to the landscape over time.
Yep.
That's just your baseline. But if a sudden massive sinkhole opens up,
Right.
like in this case an ulcer, that literally breaks open the tissue, you don't just throw some dirt in it and ignore it.
No, absolutely not.
You have to assume there was a critical failure happening underneath.
That visual hits the mark perfectly, because against the backdrop of that already compromised, really thin skin, an ulcer is an undeniable red flag.
And a scary one.
Very. The stakes underlying that red flag are really what drive the urgency of these guidelines. Patients with lichen sclerosus have an estimated 3.5% to 5% lifetime risk of developing anogenital squamous cell carcinoma.
Which is a form of skin cancer.
Yes.
Yeah.
Or its direct precursor, differentiated vulval intraepithelial neoplasia, which we just call DVIM.
So 5%. It isn't a staggering majority, but it is certainly high enough that it have to be the primary suspect when that baseline suddenly changes.
Right. And what's fascinating here is the sheer nuance required by the clinician in that very first evaluation.
Because it's hard to tell.
Exactly. Because the LS skin is so fragile, like we said, it's like tissue paper minor tears are incredibly common. We call them fissures.
Okay.
They happen from just daily friction, maybe riding a bike, or even just from the intense, uncontrollable itching that the disease itself causes.
Right, because they're scratching.
Yeah. So the clinician's very first job is distinguishing between a common friction fissure and a true persistent ulcer.
So the timeline is everything here. A standard fissure shouldn't stick around.
Right. The timeline is the great differentiator. The skin, even thin skin, wants to heal itself. If you're looking at the same open wound 3 or 4 weeks later, you have to escalate your thinking.
Which brings us to the next phase of this interrogation. We've spotted the ulcer. We know it's been there for over a month.
Yeah.
But before we rush the patient to an oncology ward, the clinician actually has to rule out a much more common, albeit frustrating, culprit.
Treatment failure.
Exactly.
Yeah.
Specifically, the patient severely underusing their medication.
Yeah, the clinical term is steroid phobia, and it is a massive hurdle in practice. Patients with LS are prescribed ultra-potent topical steroids, typically something like clobetasol propionate.
Now, I want to push back on this a little because reading through the pharmacology in these guidelines, I completely understand the patient's perspective here.
Oh, for sure.
I mean, if a patient knows their skin is already incredibly thin and fragile, and they look at a tube of ultra-potent steroids, we all taught that steroids thin the skin, right?
That's the common knowledge, yeah.
Yeah. So wouldn't they naturally want to use as little of it as humanly possible? Isn't it logical to just assume this non-healing ulcer is a severe flare-up because the patient is terrified of the medicine destroying their skin even more?
It is entirely logical from the patient's perspective, which
Yeah.
is exactly why it happens so often. They read the warning label, they see the word atrophy, and they just panic.
Right.
They apply it sparingly, or maybe only when the itching becomes completely unbearable. But here is the biological paradox that clinicians really have to explain. In lichen sclerosus, the disease itself is the wrecking ball causing the scarring and the thinning.
So the steroid isn't the wrecking ball in this specific environment.
No, the steroid puts the wrecking ball to sleep.
Oh, wow.
Yeah. LS is driven by an overactive, localized immune response. The steroid suppresses that specific immune attack. So when it's used correctly on active LS, the ultrapotent steroid actually halts the thinning and helps the skin regain its normal thickness and elasticity.
It saves the tissue.
It saves the tissue.
That is such a critical distinction. So the clinician really has to play detective here. They can't just casually ask, hey, are you using your ointment? Because human nature dictates the patient will just say yes.
Yeah. Everyone says yes. The clinician must take a meticulous, almost forensic history. And the guidelines actually give us a very clear mathematical metric to audit this.
Okay, what's the metric?
A patient should be applying what is described as a fingertip unit or a pea-sized amount to the active areas. That equates to about 0.5 grams of ointment.
Okay, tracking.
If they are doing this correctly for maintenance, a standard 30-gram tube should last them anywhere from 3 to 6 months.
I see where this is going.
Uh-huh.
So if a patient comes in with a terrifying, painful ulcer, and they proudly tell the doctor that their single 30-gram tube of clobetasol has lasted them for, 2 years.
Then the diagnosis suddenly shifts. They are drastically undertreating the condition out of fear. The localized immune system has been running rampant for 2 years. So that flare-up and the resulting ulceration is almost certainly due to uncontrolled, severe lichen sclerosus, not cancer.
But the clinician also has to look out for the exact opposite problem too, right? Like over-treatment.
Yes. Actual steroid atrophy. This happens when the patient is applying the ultrapotent steroid to the wrong area.
Like healthy skin.
Exactly. The healthy, unaffected skin surrounding the LS. That healthy skin doesn't have an overactive immune response to suppress, so the steroid just thins it out.
Oh, so it acts like a normal steroid there.
Right. The clinician will look for intense erythema, redness, and telangiectasia, which are those tiny, visible, broken blood vessels, and that's usually accompanied by a burning sensation.
So what does this all mean for the patient sitting in the room? It means the clinical visit has to be highly interactive.
Very.
A good clinician might literally hand you the tube and say, show me on your finger exactly how much you squeeze out and point to exactly where you put it.
Yeah, they have to see it.
Because if they can prove this ulcer is a result of steroid phobia and mechanical undertreatment, they can adjust the regimen, educate the patient, heal the skin, and completely avoid escalating down a terrifying cancer pathway.
You have to rule out the simple mechanical failure of compliance before you tear down the walls looking for structural rot.
Right. But let's say we do the math, and the math checks out perfectly. The patient uses exactly one 30-gram tube every 4 months.
Okay.
They apply it only to the active lesions. The compliance is golden. And yet, that ulcer is still sitting there, raw and non-healing.
Yeah.
This is where the clinical guidelines slam the brakes on medical management.
It is an immediate, non-negotiable pivot. If compliance and confirmed and the lesion persists, the diagnostic mandate is absolute. The golden rule across the British Association of Dermatologists and the European guidelines is that a biopsy is an absolute necessity.
And it is not just a casual scrape either. The sources specifically point to a 4-millimeter punch biopsy under local anesthetic.
Yeah, you take a specialized circular blade. It looks almost like a tiny apple core, actually.
Ouch.
Yeah, and you take that 4-millimeter sample from the most active, suspicious edge of the ulcer or the thickened skin immediately surrounding it.
You know, I like to think of it like taking a core sample of glacial ice.
Oh, that's good.
Because visual inspection of the surface only tells you so much, right? You can see the crack in the eyes. But to know the undeniable truth of what is actually happening, you have to drive a core down into the foundation and pull up the layers. You are looking at the historical foundational building blocks of the cells to see if they are dividing out of control.
That is exactly what histology is doing. The visual gives you the what, but the core sample gives you the unarguable cellular why. And what the pathologist is looking for inside that tiny 4-millimeter sample is remarkably complex.
Walk us through that then. The sample goes to the lab, it goes under the microscope. What is the difference between an angry flare-up and cancer?
Well, if it's just a severe patch of normal lichen sclerosus that simply isn't responding well to treatment, the pathologist will see the epidermal atrophy we discussed. Hyperkeratosis, which is a thickening of the outermost layer of dead skin cells, and a band-like infiltrate of lymphocytes in the dermis.
Lymphocytes in the dermis. So immune attack cells swarming the area.
Yes, it looks like a cellular battlefield.
No.
The immune system is attacking the skin, which proves it's an inflammatory issue.
Okay.
But if that 5% risk has actually materialized, and it's progressed to Devon-differentiated vulval intraepithelial neoplasia, the data changes entirely. The average age of presentation for Devon is around 60 years old. Under the microscope, the pathologist will see dysplastic cells.
Okay, let's define dysplastic, because we often just hear abnormal, but it's more sinister than that, isn't it?
It is. Dysplastic cells are cells that have fundamentally lost their original shape, their orientation, and their function. They're essentially forgetting how to be normal skin cells. And crucially, in Devon, these dysplastic cells in mitosis, which are cells that are actively, aggressively dividing, they're confined to the basal layer, which is the very bottom foundational layer of the epidermis.
And to be absolutely certain, the pathologist doesn't just rely on looking at the shapes of the cells, right? They use specific chemical stains.
Correct.
The guidelines note the sample will test positive for the p53 immunohistochemistry stain. Now, here is where it gets really fascinating biologically, because p53 is a tumor suppressor gene.
Right. It is. It's often called the guardian of the genome. In a healthy cell, p53 acts as the ultimate safety brake.
Right.
If a cell's DNA gets damaged, p53 steps in and stops the cell from dividing until the DNA is repaired. If it can't be repaired, p53 actually triggers the cell to self-destruct.
Okay, so wait. If it's a safety brake, why is the lab standing for it to prove it's cancer? Shouldn't finding its presence be a good thing?
This is the brilliant part of the pathology. When the p53 gene mutates and breaks down in these pre-cancerous Devon cells, it doesn't just disappear. It produces a broken, misfolded protein that can't do its job. Because it's broken, the cell can't degrade it properly, so this useless mutated protein just piles up and accumulates inside the cell.
Oh.
Yeah, so the chemical stain they use in the lab specifically latches onto that piled up, broken protein and lights it up.
That is incredible. So when the stain glows, it's literally highlighting the broken safety brakes accumulating in the cells.
Exactly.
It is the definitive cellular proof that the guardrails are gone, and this is a pre-malignant or malignant change.
It removes almost all the guesswork, but, let's step back into the clinic room for a second. The biopsy has been taken, it's off to the lab. The clinician's job isn't done just because they mailed a sample off.
No, because they still have a patient sitting in front of them with a painful, unexplained ulcer.
Right. If we connect this to the bigger picture, the clinician cannot afford to have tunnel vision here. While Devon or squamous cell carcinoma is the primary worst-case fear, they must ensure they aren't missing other overlapping conditions in their differential diagnosis.
Because the vulva is susceptible to a whole host of dermatological issues.
So many.
What else are they looking for while they wait for that P53 stain to come back?
Well, they will heavily consider erosive lichen planus. This is another chronic autoimmune inflammatory condition, but it presents differently.
Okay.
Instead of the white, crinkled tissue paper skin of LS, erosive lichen planus is characterized by glazed erythema, a very shiny, bright red appearance.
And a crucial telltale sign from the sources is that it often involves the oral mucosa,
Yes.
which means the clinician should be asking the patient to open their mouth to check for lesions on their gums or cheeks.
Which, seems entirely counterintuitive when you're evaluating a vulvar ulcer until you understand the mechanism. Autoimmune conditions often don't respect geography. They target specific types of tissue.
Right.
Lichen planus targets mucous membranes wherever they exist in the body. If it's attacking the vulva, there's a strong chance it's attacking the mouth, too.
The sources note something really tricky about lichen planus, though. They state that only 25% of cases are classic on a biopsy.
Yeah, and that is a critical point of failure in diagnostics. The histology for lichen planus can be incredibly nonspecific.
So the lab test might not catch it.
Right. A pathologist might look at that 4 mm ice core and just see a generic battlefield of inflammation with no clear markers. Therefore, diagnosing it requires what we call clinico-pathological correlation.
Meaning the doctor looking at the patient and the doctor looking at the microscope literally have to call each other and put the puzzle pieces together.
Precisely. They combine the visual shiny red appearance and the presence of mouth sores from the clinic with the lab's general inflammation results to make the official call.
Okay, what about something acute, though? Could this non-healing ulcer just be a sudden, severe infection?
Well, the guidelines dictate they might consider an acute Lipschutz ulcer. That's also known as a non-sexually acquired acute genital ulcer. But if we look at the epidemiology, the demographic and timeline are usually all wrong for our baseline LS patient.
Right, because Lipschutz ulcers are typically seen in young women, often under 20.
Yes.
They appear incredibly suddenly, and they're usually accompanied by severe flu-like symptoms.
Because they're linked to systemic viral infections like Epstein-Barr virus, not chronic autoimmune skin diseases. So it's a possibility, but highly unlikely in a 65-year-old with a 10-year history of lichen sclerosus.
Exactly. It's on the checklist, but way down at the bottom.
Yep.
Here's where it gets really interesting, though, from a systemic healthcare policy perspective. Because you have this patient, you've taken the biopsy, you are weighing the differential. But the procedural rules, particularly in the UK, according to the NICE guidelines, they take the luxury of time completely out of the individual clinician's hands.
The system is designed with a massive mandatory safety net to prevent delays in cancer care.
Yeah, according to the NICE guidelines for suspected cancer, any unexplained vulval ulceration, lump, or bleeding in a patient automatically triggers a 2-week wait referral.
That's right.
The clinician doesn't wait a month to see if adjusting the steroid cream suddenly works. They trigger an urgent suspected cancer pathway, meaning the patient must be seen by a specialist within 14 days.
And escalating to that specialist care is vital for a very specific surgical reason.
Oh, really?
Yeah. The guidelines are adamant that a clinician in primary care should not try to manage a suspected malignancy in isolation. In fact, excisional biopsies, where a general practitioner tries to just cut out the whole ulcer in their office, are strictly avoided.
Wait, why is, if you see a bad ulcer, wouldn't the instinct be to just cut the whole thing out immediately and be done with it?
It comes down to a surgical concept called margins.
Okay.
If a non-specialist cuts out the ulcer blindly, they might cut right through the middle of the microscopic cancer cells at the edge.
Oh, no.
Right. If they do that, they ruin the margins. When the oncologist eventually takes over, they have no idea if cancer cells were left behind in the surrounding tissue, or if it has already spread to the local lymph nodes.
So a messy primary care excision essentially destroys the crime scene before the real detectives arrive.
Exactly, it ruins the staging. If it is squamous cell carcinoma, the staging and treatment often involve meticulous mapping of the lymphatic system. So the patient is immediately referred to a specialist multidisciplinary vulval clinic or a gynecological oncologist.
Makes sense.
It ceases to be a single doctor's problem and becomes a highly coordinated team effort.
Okay, let's take a breath and just recap the intense journey we've just been on. Evaluating a non-healing ulcer in a patient with lichen sclerosus is the absolute opposite of a quick visual check.
Without a doubt.
It is a rigorous, multi-layered algorithm. It starts with understanding the chronic terrain and distinguishing between a temporary friction fissure and a true structural ulcer.
Then, it requires a forensic audit of the patient's compliance with their topical steroids. You use that 30-gram tube rule to separate out the patients suffering from steroid phobia.
Right, explaining that the medicine suppresses the immune wrecking ball rather than causing the damage.
Right.
And if the math checks out but the ulcer remains, the clinician pulls the glacial ice core, mandating a 4 millimeter punch biopsy from the active edge. They send it off to look for dysplastic cells in the basal layer and that glowing accumulation of broken p53 tumor suppressor proteins.
And simultaneously, they trigger that urgent 2-week multidisciplinary referral, completely avoiding messy excisional biopsies, to definitively rule out or treat Divian or squamous cell carcinoma.
It is a thorough, highly protective, and biologically fascinating algorithm. But, this raises an important question, one that really isn't neatly addressed in the flowcharts, the chemical stains, and the dosage guidelines of our sources.
No, it's not, because we have spent all this time talking about the clinical mechanics and the cellular biology. But consider the psychological toll on the patient.
Yeah.
Here is someone managing a highly intimate, often painful chronic condition, and they are told they must live their entire lives under the constant 5% shadow of potential cancer.
They are essentially tasked with monitoring their own anatomy, constantly looking for non-healing ulcers in an area that is already incredibly difficult to examine and, let's be honest, heavily stigmatized.
It's an incredible burden of self-surveillance. Every new itch, every minor tear from the friction of a bicycle seat suddenly becomes a source of existential dread.
Right.
If the medical system requires patients to be the first line of defense in spotting these red flags, if they are the ones who have to notice the sinkhole opening up in the fault line, how can healthcare systems better support the chronic anxiety that inevitably comes with that?
We have these precise 4 millimeter guidelines for finding the broken proteins. But how do we treat the hypervigilance? It is a heavy, persistent weight. And it's something for all of us to ponder as we think about what holistic, compassionate patient care actually looks like. Living in that historic house, knowing you have to constantly check the foundation for structural failure, it really changes how you experience the home.
It absolutely does.
Thank you for joining us on this deep dive. We hope this has helped you cut through the noise, understand the mechanisms beneath the medicine, and spot the signals that really matter. Keep asking the hard questions, and we'll see you next time.